Swaddi from Thailand. My name is Arunwan Pratipan. I'm the president of APPS, or Asian Pediatric Pulmonology Society. Welcome everybody to the 5th APPS Grand Round. This one is hosted by our Oman friend. As you know, this event is free for all to join. It is APP's strong intention to create cooperations between pediatric pulmonologists in Asia and deliver knowledge to pediatricians of the world. I would like to thank all speakers, presenter, and moderator who volunteer to conduct this grand round. Thanks Oman Respiratory Society, especially Associate Professor Hussein Al-Kindi. He is the Senior Consultant and Head of Pediatric Pulmonary Unit, Muscat, Oman. And he is now will be our moderator for today grand round. So please welcome Professor Hussein Al-Kindi.
Thank you, Professor Anwan. Assalamu alaikum, everyone, and good evening. I'm very excited today to be the moderator for our grand round, and I will quickly introduce our speaker, who is Assistant Professor Dr. Nawal. She's a consultant pediatric pulmonologist at Sultan Qaboos University Hospital, and she will be our presenter tonight. And in the panel, there are 3 panelists. First is Prof. Kapra from India, then Prof. Ann from Singapore, and Prof. Ibrahim from Qatar. I wish all of you good learning opportunities. Please, Dr. Nawal, start the presentation.
Thank you, Dr. Hussein, and thanks you all for attending this grand round. The title of today is CF, Huff, Puff, and Bump. So we'll be talking about a 9-year-old female child who is having pancreatic insufficient cystic fibrosis. She was diagnosed at the age of 8 months with cystic fibrosis following her presentation with poor weight gain, chronic diarrhea, and recurrent chest infection. Her CF diagnosis was confirmed with a very elevated sweat chloride at 96 millimole per liter, and her CFTR gene mutation came back positive as homozygous S549A, which is the commonest mutation here in CF population in Oman, and it is a gate mutation. Her best FEV1 over past 12 months was 84% predicted. Her sputum cultures chronically growing MSSA and intermittently growing Haemophilus influenzae. Her growth parameters have been tracking at the 3rd percentile, and she has no CF comorbidities like CF-related diabetes or CF-related liver disease. She's currently on airway clearance therapy, including salbutamol and 7% hypertonic saline, BID, followed by chest physiotherapy. She's using a oscillatory BEP device in the form of Acapella twice daily. For nutrition, she is on a pancreatic replacement enzyme, that's Crayon 10, and a fat-soluble vitamins in the form of ADIC. She's also taking extra salt in the form of sodium chloride tablets. Next. For those who are interested in learning more about airway clearance therapy and bronchiectasis, I would highly recommend this website. It's called bronchiectasis.com.au, and it has all kind of audiovisual materials to help you understand airway clearance therapy in bronchiectasis, as we are not going through that today. Her nutrition has been an issue as her BMI on the 3rd centile. However, she is closely monitored by our CF dietitian. A trial of oral caloric supplements have been trialed, but it was not successful. As any child who is suffering from a chronic illness, social history is important in these cases. So she is living 3 hours away from our hospital. Her father works in an oil company with 2 weeks on-off schedule, causing transportation issues. She is performing excellent at school and currently in grade 4. So I'll take you in the coming minutes through the journey and a key highlight moments in this child's health journey at our center. Hopefully, we learn through those encounters some of the CF-related complications and comorbidities and how to manage them. So we'll start in January 2022 when she presented with 7 days history of upper respiratory tract infection symptoms associated with increased cough and thick yellow sputum production. Otherwise, she had no fever, shortness of breath, chest pain, or hemoptysis. Her examination revealed a well-looking child whose weight and height and BMI is tracking at the 3rd percentile. She had no increased work or breathing, and her vitals were within the normal limits. She had obvious digital clumping, and her chest auscultation revealed few crackles at the right base. The previously documented chest auscultation of this child was a clear chest. Rest of her physical examination were unremarkable. Her spirometry during that clinic encounter showed an FEV1 at 82%. And if you recall, her baseline FEV1 percentile was 84%. So there's no significant drop in FEV1 during this clinic encounter. As always, when you're having a child with chronic changes on the lungs, you always have to compare to the previous film. So if you look at the previous film and the current film that obtained during this clinic encounter, you would see increased peribronchial thickening and some mucus impaction, especially the area where at the cardiophrenic angle on the right side, where there's much denser opacity compared to the previous. So our impression was CF pulmonary exacerbation. And based on her last sputum culture result that showed a methicillin-sensitive Staph aureus, she was given a 14 days course of oral cloxacillin. Her airway clearance therapies have been increased from BID, which is the baseline that she is doing on a daily basis, to TID. And a follow-up sputum culture results were, or a new sputum culture was sent actually during that clinic visit. This culture grew Pseudomonas aeruginosa. We also sent the same clinic visit a non-tuberculous mycobacterium culture that came back later as negative. So this is the first poll for the audience. And it's how would you manage the first growth of Pseudomonas aeruginosa in a CF patient? Please select all that apply. Admit for IV antibiotic, inhale colistin with oral cipro, inhale tobramycin, or inhale tobramycin with oral ciprofloxacin. The poll is open for 30 seconds. So 38% said they would admit for IV antibiotics. Another 1/3 said they would give inhaled tobramycin with oral ciprofloxacin. And a 19% said inhale colistin with oral ciprofloxacin. Only 3 to 7% said either inhale colistin alone or inhale tobramycin alone.
Yes, at this stage, I would like Prof. Kapra from India to tell us about how to manage such patients when they first present with Pseudomonas as cystic fibrosis patient.
Greetings from India, and I'll be discussing about what happens if Pseudomonas is grown or identified in the airway secretions of a child with cystic fibrosis. So, as we are aware, CF is a multi-system disease, but the primary cause of death is respiratory failure resulting from chronic pulmonary infection due to Pseudomonas aeruginosa. So it is very important. Once established, it appears to be permanent and very difficult to eradicate. And definition of chronic Pseudomonas infection is very variable depending on which guideline you are following. So treatment for first-time Pseudomonas include inhaled antibiotics such as colistin and tobramycin, oral quinolones such as ciprofloxacin, and intravenous antibiotic as it was evident in our poll. Treatment of first in isolation may have the potential to prevent or delay infection of the respiratory tract later on. Most of centers advocate frequent microbiological surveillance and attempt to eradicate Pseudomonas when it first appears in the lungs. So, what are the evidence? As it is very evident that it is a variable practice going on across all of our countries. So, what are the evidence and what I should do? So, salient finding of a Cochrane systematic review published recently in 2023 that nebulized antibiotics or a combination of nebulized and oral antibiotics were better than no treatment in treating early infection with Pseudomonas, which was eliminated in the majority of individuals. IV antibiotic did not confer an added benefit over the use of oral antibiotic. Eradication may be substantial in short term, and there will be a recurrence or relapse. There is insufficient evidence which antibiotic strategy should be used for the eradication of early Pseudomonas infection in CF. So this is of a review of all the studies carried out till now. And then CF Foundation US strongly recommend the use of inhaled tobramycin 300 milligram twice daily for 20 days to treat initial or new growth of Pseudomonas from an airway culture. So what shall I do in such a situation when there is no clear decisive evidence for one or other regime? So if a child is asymptomatic, then inhaled antibiotic like tobramycin, colistin for 4 weeks should be sufficient. And if child is symptomatic in form of exacerbation like our patient, then there is a need for systemic antibiotic. It may be oral or IV depending on the sickness of the child. So it would be antimicrobials along with inhaled antibiotics. So what is the how I manage if it is a chronic Pseudomonas? So chronic endobronchial infection with Pseudomonas aeruginosa is common among patients with cystic fibrosis and often leads to exaggerated inflammatory response in the airways. The acquisition of this microbe is associated with a more rapid decline in the lung function and earlier mortality. It is hypothesized that Pseudomonas aeruginosa infection initially occurs transiently and then progresses to chronic infection by developing a mucoid phenotype. And mucoidy of a Pseudomonas transformation is thought to contribute to the development of difficult to eradicate or persistent infection. So how I treat? Persistent bacteria are difficult to eradicate, and inhaled antibiotic strategies with higher airway concentration with minimized systemic toxicity are required to prevent progressive lung damage. Currently approved inhaled antibiotics on the market are limited. Tobramycin, aztreonam, colistin, and under approval are levofloxacin and murapavadine. So by going by the current evidence, I can conclude that if we can use monotherapy, that is tobramycin or colistin inhalation for 4 weeks, and the regime may be 4 weeks you are giving daily, 4 weeks is a holiday, and then again 4 weeks we are giving. But if it is difficult to eradicate or control, then combination of medications like tobramycin, colistin, or aztreonam, it may be given alternate month, and some units prefer to add IV antibiotic for 2 weeks every 12 weeks regularly. So these are the regimes. Like monotherapy will work in majority, 4 weeks on, 4 weeks off of either colistin or tobramycin. Difficult to eradicate, then combine 1 month of one medication and followed by another month. And if you are very much worried, then 3 monthly, 12 weeks of IV antibiotic may be given.
Thank you, Prof. Kaffer.
So back to our patient. We have seen her virtually in a week time, and her cough actually reported to have been improved. Not fully back, though, to baseline. Otherwise, she's active and she's back to school. So we treated her with inhaled colistin 1 million unit BID for 3 months and oral ciprofloxacin for 14 days, given that she was having still higher wet cough compared to baseline. We use typically in our center inhaled tobramycin. However, remember this is 2022 and we are just out of the pandemic. A couple of medications are on back order in our center, including tobramycin inhalation. She was seen in 3 months' time, and this time she has no cough, she's active, good appetite, her BMI is tracking at the 3rd centile, and her physical examination is unremarkable, including a clear chest on auscultation. We obtained a sputum culture to document eradication of Pseudomonas, and this came back as positive only for Staphylococcus aureus. So this is successful eradication of Pseudomonas considered. She came back in 6 months' time, this time a routine follow-up clinic, but she was symptomatic. She reported to have an on and off progressive wet cough for the past 3 weeks. It started as upper respiratory tract infection symptoms. In Oman, we have on and off sandstorm. So it was the time where it was a dusty weather during that time as well. She had increased sputum production, green, thick, but no blood. And she has been during the summer break, school summer break here in Oman, June to end of August, suboptimally adherent to her airway clearance therapy. She was seen in a health facility locally and was given oral cefuroxime. However, they reported no improvement with that. On physical examination, her oxygen saturation 95% room air, which is slightly lower than what used to be her oxygen saturation, which is 98 to 97% in room air in routine clinic visit. She lost almost 800 grams since her last visit. She was having still digital clipping, and her chest revealed a reduced air entry to the right side with the crinkles on the right side as well. Rest of physical exam was unremarkable. Her spirometry showed a significant drop in her FEV1 from 82% the previous visit to 55% this visit. Her chest x-rays is showing more and more bronchial coughing and thickening. And if you to look at that airspace patch on the right upper zone, it is increasing, as well as the one in the cardiophrenic angle on the right side as well. Hence, she's having the crinkles on physical examination. Her sputum culture showed a heavy growth of Pseudomonas aeruginosa that's sensitive to Cipro and other antibiotics. So we consider this recurrence of Pseudomonas aeruginosa infection following initial successful eradication. Because she was very symptomatic clinically and there's a significant drop in FEV1 and new changes on the X-ray, she was admitted to the hospital, received IV piperacillin, tazobactam, and gentamicin for 14 days. And as you see at the day of discharge, day 14, her FEV1 has been back to baseline at 82%. She was discharged on inhaled tobramycin, 300 milligrams BID alternative months for chronic Pseudomonas infection. 2 months later, she was seen for follow-up and she was doing very well with no new concern. She turned 10 years of age at this visit, and so she is due for a CF screening evaluation for CFRD. So in our center, we do oral glucose tolerance test. And for this girl, it was normal at that visit. We also do a screening for CF-related bone disease using DEXA scan. And this showed a low bone mineral density. Her Z-scores for the spine were minus 2.5. So she was referred to our endocrinology team for evaluation of CF-related bone disease. Now, a year after all of that, we are now in January 2023. She came in for a follow-up, having a 6-week history of upper respiratory tract infection, progressive productive cough following that, with increased sputum production that's thick and yellow. It was significant that she is having shortness of breath with exertion. She has reduced appetite, but no chest pain or hemoptysis. Her physical exam showed a low oxygen saturation at 94%, though it is within the normal limits, but it is lower for her baseline. She was tachypneic with a respiratory rate at 30, with moderate work of breathing, including suprasternal inter and subcostal recessions. Her chest auscultation revealed reduced air entry with crinkles on the right lower zone, otherwise no wheeze, and rest of physical examination was unremarkable. Her spirometry showed dramatic drop in FEV1. Remember, she was discharged with an FEV1 of 82%. Now we are at 34% drop, 34% predicted of FEV1. So that's a remarkable drop in FEV1, consistent with her being very symptomatic during this visit. So her investigation at this time, CBC was performed, and it is throughout looks normal, apart from a significant blood eosinophilia at 16.9 percentile. Her CRB was within the normal limits. Her blood gas was normal. Her biochemistry, including LFT, UE, and glucose, were all within the normal limits. Her sputum culture, this visit, showed only Candida, which was thought to be upper airway contamination. So she was admitted and started on IV ceftazidime and imicacine, trying to target the possible organism, which is Pseudomonas. She was started on airway clearance therapy 3 times daily with our physiotherapist. She showed a partial improvement with IV antibiotics after 5 days. So her FEV1, when she presented, was 32%. 5 days into antibiotic, it improved to 47%. There is no significant post-bronchodilator change. If you look at the lung volumes, you would see that she's having significant air trapping with RV over TLC 61%, which is more than the lower limit of normal for her, which is around 22%. So we proceeded with chest CT. And there are 3 kind of major findings on those cuts from her chest CT. The first one is you can see a significant mosaic attenuation where you see areas of ground glass opacity and next to areas that look like an air trapping. Second thing, there's central bronchiectatic changes. And the last thing is if you see at those white kind of patches and compare them to mediastinal windows on the other side, you would see she's having a dense mucus impaction as it is more dense compared to the paraspinal muscles. Those cuts also on the lower lungs showing exactly the same thing that I mentioned earlier. So this is extensive, high attenuated mucus impaction. We proceeded with flexible bronchoscopy, and this showed, again, significant mucoid impaction that was really difficult even to suction during the bronchoscopy itself. This is actually one of the bronchoscopy images for the child herself. So our second ball here, to engage the audience, what additional investigations would you request at this time for this child? Serum total IgE, peripheral blood eosinophils, Aspergillus fumigatus specific IgE or specific IgG, skin prick test for Aspergillus, serum precipitant against Aspergillus or other tests. Please select all that apply. And so almost 50% said Aspergillus fumigatus specific IgE, and rest serum IgE 20%, a 12% for Aspergillus fumigatus specific IgG. Few only asked for a skin prick test and a serum precipitant against Aspergillus. Excellent. So for this patient, we sent for a total IgE that is came back as significant at around 100 or 1,200. Her previous total IgE that was documented was 45. So there's a significant or remarkable increase. Her anti-Aspergillus specific Aspergillus specific IgE was also elevated. At our center, we don't have access to anti-Aspergillus antibodies IgG unless we requested as an external test. So we didn't thought it is needed at this case. Her cultures from the flexible bronchoscopy with lavage showed a growth of Aspergillus flavus, a growth of Aspergillus terus, and her non-tuberculous mycobacterium culture came back negative. The bowel fluid cytology revealed abundant neutrophils and eosinophils, and the cell block in the cytology showed also few scattered fungi consistent with Aspergillus.
I would like to invite Prof. Ann, our second panelist, to tell us about how to manage allergic bronchopulmonary aspergillosis, as it seems that our patient has been diagnosed with this one at this stage. Please, Prof. Ann.
Thank you, Hussein. So how would you define allergic bronchopulmonary aspergillosis, or ABPA for short? And that's basically a diagnosis when the causative pathogen is Aspergillus fumigators or any Aspergillus species. And in this condition, it's usually found in either children with asthma or cystic fibrosis. So there must be a background of asthma or cystic fibrosis. Now, if the organism isolated is any other fungus outside of Aspergillus, then it is called allergic bronchopulmonary mycosis, or ABPM for short. Okay. The clinical diagnosis of ABPA requires a high index of suspicion. It occurs, think about it, when you have a child with increased wheezing or chest tightness or chest pain, especially if the child is failing to respond to antibiotics and inhaled medications, or if the child looks unwell with fever and malaise, and in particular, if there's very thick sputum with brown or black bronchial casts. There's the ISHAM ABPA work group recently came up with a consensus criteria, and the ISHAM is actually the International Society for Human and Animal Mycology, for diagnosing ABPA. And essentially, as I mentioned, there must be predisposing conditions, especially mainly asthma and CF. And most of these children will have bronchiectasis. The essential components for this diagnosis, obviously, is the isolation of Aspergillus species, particular Aspergillus fumigatus, specific IgE, which must be more than 0.35 kilounits per liter. And in the UK guidelines, basically what they found is that a level of Aspergillus fumigatus specific IgE more than 5.7 kilounits per liter is very highly indicative of ABPA. It's almost 100% sensitive and 94% specific for this diagnosis. The serum total IgE is usually raised as well, more than or equal to 500 international units per mil. The other components that are present in this diagnosis, and you just require any two of the following, either a positive IgG against Aspergillus fumigatus or a blood eosinophil count of more than 500 cells should be documented. Or on a CT scan of the thorax, there should be features consistent with ABPA, such as the presence of bronchiectasis, the presence of mucus plugging, particularly if you can see high attenuation mucus, as mentioned by the presenter previously, okay, or fleeting opacities on the chest X-ray, which are then consistent with ABPA. In fact, what they find is that if you see the presence of high attenuation mucus, it's almost pathognomonic of ABPA. So this is a diagnostic algorithm for ABPA as suggested by the ISHAM ABPA work group. Basically, if you have a compatible clinical presentation, you want to isolate the presence of Aspergillus fumigatus based on a specific IgE. If you get a level that is more than 0.35, you suspect it, okay, and you do supporting tests such as the serum total IgE, which should be more than or equal to 500 international units per mil. You want to look at the bronchial eosinophil count, the blood eosinophil count, sorry, and that should be also raised at more than 500 cells per microliter, and you will demonstrate a high Aspergillus fumigatus IgG if you can do it, okay. Following that, you would want to do a CT, chest, thorax, and looking for specific features of ABPA. And what if divided the features on the CT scan, you can then call it according to what you see on the scan. So if there's no presence of bronchiectasis, it's just serological ABPA. Whereas if there's bronchiectasis, you'll say that's ABPA with bronchiectasis. And if you have high attenuation mucus, then it's APPA with high attenuation mucus and so forth. If without the presence of Aspergillus present, then if you find other fungal infections, then it could be ABPM as the cause of the disease. So they've actually come up with a clinical classification and a treatment response criteria. So the classification of APPA obviously can be diagnosed, can be acute APPA, it can be newly diagnosed, or it can be an exacerbation, right? And a newly diagnosed APPA is one where the child has never had a previous diagnosis of ABPA and meets diagnostic criteria. Exacerbation is a child who now is diagnosed with ABPA and has sustained clinical features, either with clinical worsening of more than 14 days or a radiological worsening, and there's still increase in the serum total IgE by more than 50% from the last recorded IgE value during clinical stability, along with exclusion of other causes of worsening, then you define that as an exacerbation. What is defined as a response is a symptomatic improvement by at least 50% on the Likert scale or visual analog scale after 8 weeks. And there must be also major radiological improvement of more than 50% reduction in radiological opacities or a decline in the serum total IgE by at least 20% after 8 weeks of treatment. A remission is defined as a sustained of more than 6 months clinical radiological improvement after they've come off steroids. And there must be no rise in the serum total IgE by more than 50% from the last recorded IgE value during clinical stability. A treatment-dependent APPA is one where 2 or more consecutive APPA exacerbations, each occurring within 3 months of stopping steroids. And there's worsening of respiratory symptoms as well as worsening of imaging or a rise in the total IgE by 50% within 4 weeks of tapering oral steroids on 2 separate occasions. So in other words, these are children who cannot come off steroid treatment or steroid tapering. Okay. And there's continued APPA exacerbations. Advanced APPA is one where there's extensive bronchiectasis due to APPA on chest X-ray, or there's presence of core pulmonary or type 2 chronic respiratory failure. Next. How then do you treat APPA? And the principles of treatment is really to suppress the exaggerated inflammatory response, because APPA is a type 2 inflammatory response which is triggered by the presence of Aspergillus. Okay, and hence using an anti-inflammatory agent such as steroid to suppress this type 2 inflammatory response is the mainstay of treatment. So you can use systemic glucocorticosteroids, and now there are some studies looking at the use of biologics targeting interleukin-4 receptors or interleukin-5 and interleukin-13 receptors as well. And because it is triggered by the presence of Aspergillus, you also want to inhibit the growth of the fungus, which is responsible for the ongoing inflammation with the use of antifungal agents. Therefore, the treatment goals are to control the symptoms and prevent future risks of ABPA exacerbations. So if you think about it, then therefore, the use of steroids and oral steroids are usually sufficient with antifungal treatment should be the main treatment agents. However, ISHAM actually has suggested that you can use either prednisolone at 0.5 milligrams per kilogram per day for 2 to 4 weeks, then taper over 4 months. And they actually say that you can do or oral itraconazole over 4 months if systemic steroids are contraindicated. So for ISHAM, they say you can do either steroids or antifungal. However, if you look at most CF centers and in most consensus statements for management of CF, most CF physicians would agree that they would rather treat with both. So they will always start prednisolone together with antifungal treatment, okay? And so I've given you a few recommended regimes here because unfortunately there are no standardized regimes. The CF Foundation Consensus Conference came out with a suggested regime in 2003, and Australians have published this as a suggested regime just recently, but I've also shown here the UK Royal Brompton Hospital regime, and they have slight differences between regimes, but basically what they would use would be prednisolone, either at 1 milligram per kilogram. The maximum dose can differ, as you can see, for 2 weeks, and then taper that dose over a period of, in the own paper, which is the Australian paper, they said over 10 weeks, usually lasting for about 3 to 6 months, and the antifungal treatment will occur concomitantly at a minimum of at least 6 weeks during the course of the steroids. I've also put here the Royal Brompton Hospital regime, and they start at a dose of 2 milligrams per kilo with a maximum dose of 40 milligrams for 2 weeks, and then they reduce by 10 milligrams per week, and they will review at 4 weeks for clinical improvement when the prednisolone dose has reached about 10 milligrams, and if it's improved, they will then decrease to 5 milligrams for 1 week and stop. So they basically try to use a very short regime, and they will start posaconazole as their antifungal treatment with the steroids, and they will stop that when steroids are stopped. House IV methylprednisolone is only reserved for non-adherent patients, and the regime is 10 milligrams per kilo for 3 days per month for 3 months, and then that will be stopped as well. Okay. The reason or the rationale for the short course caused by the UK Royal Brompton Hospital is that now many of the patients with CF are on CF modulators, and the dose of CF modulators will need to be adjusted if the patients are on azoles, which are the main fungal agents. And so therefore, they will want to shorten the course as much as possible so that these patients can be continued on their CF modulators. For ABPA exacerbations, the treatment is similar to acute ABPA. However, you can consider, again, combinations of oral prednisolone and itraconazole in those with recurrent exacerbations, more than 2 in the last 1 to 2 years. And this was the ISHAM recommendation. So you see that they actually had recommended either steroid or itraconazole. For exacerbations, they are recommending the combination. And again, consider IV methylprednisolone if oral steroids fail. Always remember on follow-up to do spirometry, trend the total IgE, and repeat the chest X-ray at 8 to 12 weeks or later to look for response. In the UK protocol, in fact, they do it at 4 weeks to look at response because they really want to shorten the course of their treatment. A relapse treatment, basically, relapse is possible for up to 2 to 3 years after the first episode. And if it occurs, repeat the course of oral steroids or give IV methylprednisolone if the relapse occurs within a year of the first episode. And alternative treatments can be considered, such as nebulized amphotericin and some biologics such as omalizumab. Thank you.
Thank you very much, Prof, for this very concise review. And now we'll go back to our patient by Dr. Nawal.
So this child was managed with IV antibiotics for 14 days to cover for Pseudomonas. Prednisolone was started at 1 milligram per kilo OD for 2 weeks, and then half milligram per kilo OD for 2 weeks. Itraconazole, because of the severity of her presentation, as well as intermittently she was requiring oxygen during this admission, we elected to actually combine both prednisolone and itraconazole. Supplements, vitamin D, calcium supplements, and monitoring of vitamin D is of a key here because she does have a low bone mineral density, and being on steroid is a risk factor. 4 weeks later after that admission, she came for follow-up in the clinic. She has no more cough or shortness of breath. She's complaining of no chest pain or hemoptysis. Her examination, blood pressure, since she's on steroid, was normal. SpO2 was normal in room air. She's gaining weight, and her chest in auscultation now is clear. Her FEV1 had improved from 34%, 47% to 74% in 6 weeks being on systemic steroids. Her total IgE had dropped significantly from 1,200 to 500 at 6 weeks. While being on steroids is of a key important to monitor for blood pressure as well as glucose. So her glucose during that visit was 6 millimole per liter. Her chest X-ray was repeated. We didn't have the X-ray film from that first admission. We had the CT. So I used the Scout film from the CT here to compare to the X-ray. And as you clearly see, the obesities, especially on the right upper zone, the right middle area, and the retrocardiac area had improved dramatically. Her prednisolone weaned low for 8 weeks. Itraconazole continued for 3 months. We were monitoring for side effects. She came back to the clinic for follow-up with the complaints of polyuria, polydipsia. She have lost 1 kg since last visit. She is having low mood related to frequent admission to hospital. Her chest auscultation revealed poor air entry bilaterally, otherwise no crackles or wheezing. And her investigations, as you can see here, showed a ketotic hyperglycemia. So her urine ketones were 3+, her serum glucose was 28, and she did not have any metabolic acidosis in venous blood gas. So this is hyperglycemic ketosis. She was managed with the help of our endocrinology team with insulin, with the thought this might be steroid-induced diabetes mellitus, or this is a CF-related diabetes induced by steroids. Steroids were tapered off over the next 2 weeks. She completed a total duration of steroids of almost 10 weeks. And at the time where steroids were stopped, her IgE has normalized to 86. Her glucose also normalized after tapering steroids off, and she has been off insulin 2 weeks after discontinuing a systemic steroids. So this was likely steroid-induced diabetes. 4 weeks later, we received the good news of approval for her to start on the CFTR modulator, which is ivacaftor, the oldest one. Her we typically in our center do some initial investigations. So her pre-ivacaftor workup showed that weight was 21 kg, her FEV1 at 86% predicted. Her sweat chloride before starting ivacaftor was 98 millimole per liter. As you know, ivacaftor is associated with liver transaminitis and in rare occasions also a cataract. So her eye exam and liver enzymes initially all were within the normal limits before initiating ivacaftor. 4 weeks post ivacaftor, next. If you can show all the lines, yeah. Her weight had increased by 1.2 kg. Her FEV1 has been the best ever she had at 90% predicted. Liver enzymes remained within the normal limit. Her sweat chloride normalized from 98 to 92. This is just her spirometry showing the FEV1 at 90%.
Great. So now I'll ask Prof. Ibrahim to tell us more about CFTR modulators, since our patient did so well after starting it. Prof. Ibrahim, please go ahead.
Thank you so much, Hussein, and thank you, APPS, for inviting me to be on the panel today. In order for us to understand the modulators, how they work, we need to understand how the CFTR is made, how it is formed. So as we all know, any protein is made in the nucleus. So this is just a cartoon showing how this is made. So it's obviously it's formed in the nucleus, starts to be modified in the plasma reticulum and Golgi apparatus, and it starts trafficking all the way to the cell surface, where CFTR starts working as a gate for chloride. And that is the normal function for CFTR that basically controls the move of chloride in and out of the cell. Now, as most of us know, that CF is classified into different classes. There are 6 classes. They depending on what is the molecular defect. So in class 1, basically it's not made. So the nucleus does not make a CFTR protein. So that's class 1. And there are some examples in this cartoon. You can see that there are examples of the mutations or the variants that we can exemplify this class of mutations. In class 1, you got the G542X. That's an example of no protein is made. The next class 2, is the protein is made, but it does not traffic properly. So there's a defect in the traffic of the protein to the cell surface. And that is the most common example, is the most common Caucasian mutation, which is delta F508. That's a class 2. And then we have the class 3, where it actually is made and it traffics nicely to the cell surface, but it does not work. So this is where the gate is impaired. The gating is, and these are the types of mutation that we call gating mutation. Is one of the gating mutations, a class 3 mutation. A good example is the classic G551D, where the ivacaftor was tested on to start with earlier on, almost a decade ago. We move on to so these class 1 to class 3 are classified as severe mutations, ending up with rather severe disease, depending on how it's penetrated, how much it's penetrated. And then we move on to the milder, quote unquote, milder mutation, where class 4, 5, and 6 are. Class 4 is also called a gating mutation, but the problem is basically it goes all the way. So it is made, it traffics nicely, it goes to the cell surface, but it functions in a defective way. So it's not the best function. So basically, it does not work as good as it should, and we call this defective conductance. And a good example of that's another common one. Another common variant is R117H. Then we go to class 5, where everything looks good, but the amount is low. So it's reduced synthesis. Everything is fine. The protein itself looks okay. It goes to the self-service, positions itself nicely, but the amount that is made is not adequate, and therefore you end up with CF phenotype. Class 6, there is everything is good, but it's unfortunately the protein itself is not that stable. It breaks down quicker than usual. Usually, the half-life of this defective of the protein is less than half of the half-life of the normal one. So here we go. Now, how do we approach this? So we have a bunch of medications that are basically targeting the different defects that we have. This is just a very quick review of what we've just discussed. And how do we approach it? So the required approach in the class 1 is to basically rescue the protein synthesis if possible. Class 2, you need to correct the protein folding so it can move on to where it's supposed to. Class 3, you need to restore the channel function and conductance. Class 4, very similar. You store the class channel, the channel conductance. While class 5, we need to help in maturation and correct the missplicing. While in class 4, you want to make the protein more stable. So what do we have in terms of medication? All right, so there are 4 modulators that are approved and available. Let's start from down there, Kalydeco, which is ivacaftor, the first one that was introduced in the market. The next one is Orkambi, which is lumicaftor, ivacaftor, and the next one is Symdeko, tezacaftor and ivacaftor together. And then the latest is Trikafta, which has triple medication, elixicaftor, tezacaftor, and ivacaftor. Start with the first one, which is Kalydeco, and this patient was started in this medication. It's a potentiator, so it basically potentiates the function of the CFTR, and it's perfectly fit for patients who have gating mutation. Orkambi was introduced about more than 5 years ago. It basically has lumicaftor as a corrector and ivacaftor as a potentiator. So it combines both of them. And then Symdeko was a modification of the previous product. It has tezacaftor as a corrector, and it still keeps ivacaftor as a potentiator. It had less side effects such as just tightness and drug interaction than Orkambi. The age at which you can start this medication is 6 and above, and it was mainly for Delta F508 patients with 2 copies of this medication. But then the indication of Symdeko was expanded to a single copy of one of the more than 154 different mutations. The latest one, which is the most commonly used these days, is the combination of the 3 of them. So we have the elixicaftor and tezacaftor, which helps to fix the flaws in the CFTR protein. So it can be, it can really form the right shape and traffic to the cell surface. And then we have the ivacaftor, which is part of this regimen. And ivacaftor does what it does the best, which is potentiate the function of the gate right there. Trikafta has been approved for people with cystic fibrosis from 2 years of age all the way up. And they need to have at least 1 copy of Delta F508 or at least 1 copy of more than 177 different specified mutations. Now, it's important to notice here that these modulators are not fit for every CF patient. They need to have the right mutation. They need to be tested. And typically, what we do is we do in vitro testing. And sometimes you have to use organoids to test the medication in the lab and see whether it works for the specific mutation that a given child has before we start this medication on them. Now there are websites that you can look up your mutation and see whether they will fit or not. At least one of them has more than 600 different mutations that you can cross-check whether any of these medications work for them. And I would definitely advise not to start anybody on any of these medications until you know that it works, because they are extremely expensive.
Thank you very much, Prof. Ibrahim. And I would like also to give you just brief summary of the experience we have in Oman. We have the almost more than 52% of our patients carry S549R, which is one class 3 gating mutation. And in my hospital, we started it since 2016, slowly with 4 patients. And now we have 30 patients on this medication. And I'm just showing you a summary of some of these patients who had been given the medication, how much they improve when they are on this treatment. Within 6 months of treatment, the weight goes up very nicely, and also their spirometry, FEV1, picks up very nicely. Actually, patients give you a very positive result that they feel better, they feel more normal, no more coughing in the morning, no more sputum. We go back to our patient, Dr. Nawad.
So I hope you enjoyed the journey with us today. We talked about the Pseudomonas first growth, eradication, chronic Pseudomonas infection. We talked about ABPA and CF, and then we took it with CR regulators. So I want you to take a few key home messages from this month's ground round. That early diagnosis of CF is important, especially in the era of new therapies. Remember, CF used to be a Caucasian population disease, but we know it now. There are a lot of Asian and Middle Eastern kids who are having actually cystic fibrosis. And so keep an eye on the clinical presentation and always keep CF in your differential lists. When it comes to Pseudomonas eradication, early surveillance and detection of Pseudomonas is of paramount for these kids. Early attempts for eradication of Pseudomonas would prevent a chronic lung infection with Pseudomonas as well as rapid deterioration in lung function. When it comes to ABPA, CF is one of the diseases that associated with this disease, and regular screening and prompt treatment for ABPA is important in pediatric patients with cystic fibrosis. And lastly, we are in the era of new therapies for cystic fibrosis, and it's very promising, though those medications are very expensive and yet not accessible to everybody, but they are coming. And we should be ready when the time comes that those drugs are available for every CF patient that we are taking care of. So thank you all for coming to Ground Rounds today, and I'll hand it to Dr. Hussein and the group.
Thank you very much, Dr. Nawal and the panelists for excellent presentation and going through a very dense material of knowledge. I hope people enjoyed the presentation and learned something. And because of lack of time, unfortunately, we will not have any question and answer session. So at this moment, I would like to hand over the mic to Prof. Karinder Singh from India, who will take the lead in the final essay. Thank you very much.
Thank you, Professor Hussain. It was an excellent discussion we had today, and I'm sure the audience enjoyed it. So on behalf of our president, Dr. Arunwan, I thank the presenters, Professor Hussain, Dr. Nawal Shamli, and also the discussant, Professor Engo, Professor Kabra, Professor Ibrahim, for giving great inputs to the case while we were on this. So, ladies and gentlemen, you have been enjoying this scientific treaty which comes on behalf of the APPS, and we're going to have another grand round on 20th September 2024, where we're going to discuss another exciting story about not one patient, but this time two patients, two sisters with persistent wet cough. The challenges, they are coughing with hand in hand. What's happening there? And that story would be told by none other than Dr. Daniel Eng and his team from Hong Kong. As you know, Dr. Daniel Eng is the founder, president of APPS, and the key person behind this organization. So we look forward to seeing you on 20th September 24 for our next grand round. And also to remind you that APPS stands for a lot of good scientific activities, and this year's scientific meeting, the annual meeting, would be held, is going to be organized by Professor Hussain Kindi at Oman, and we welcome you all to join us for the meeting in December, from 12 to 15 December in Oman, Muscat. So you can present the, from 13 to 15, I'm sorry, and you can submit papers as they would open up for discussions, and join us, register in large numbers for an exciting meeting where we will discuss more about diseases of pediatric pulmonology in the context of Asia and Pacific. Thank you very much, and thank you for joining us today. My heartfelt thanks to the presenters as well as the discussion today. Thank you.
Thank you all. Excellent job, and physicist, our behind the scene controller. Thank you very much for the hard work, and I wish you all a pleasant evening.